And I would challenge most people in the room, actually, and people will know me, that most of us in our countries have a much simpler job than Egypt. And if Egypt can be doing that under the circumstances in which Egypt's working, then the rest of us just aren't trying. So all of us have got to lift our games and stop making excuses. With that, I'll give my disclosures. In particular, I get funding from Gilead Science, AbbVie and BMS for investigator-initiated research projects. I'm going to give a brief overview, talk about elimination and why it's really possible, and in developed countries in particular, where we have money. It's how we choose to spend it, why we should be able to do this. And I think it's, even in resource-limited countries, and if you again look at, and countries with huge epidemics, what Egypt's achieving, why we should be trying harder. Talk about Australia's progress to date, what needs to be done to achieve our elimination targets, and then what work has started to do that. We've seen this before, lots of disease, and we need to change this. In many developed countries, the epidemic, and you have to actually understand your country's epidemic, and I think that's a really important thing to say, so I'm talking about Australia, but epidemics vary across countries, and I think Godfrey talked about this, understanding of the epidemic so that you know what you need to be doing in your own country. In Australia, our epidemic is predominantly driven by people who inject drugs, involved in unsafe injecting because they can't access clean needles and syringes, or opiate substitution therapy. As well, some of our transmission is occurring within gay and bisexual men who are HIV infected, but predominantly our epidemic is people who inject drugs. So if we're going to eliminate hepatitis C as a public health threat in Australia, we need to understand that and understand what we need to do about that. I think we also have to understand that people who inject drugs are highly stigmatised, and that's mostly the fault of people like us in this room. And if we all had different attitudes in terms of in healthcare settings, in health services, in the community more generally, perhaps we wouldn't have such a problem. If we had a different attitude to the issue of drug use and injecting drug use, perhaps we wouldn't have this problem globally. In Australia, to date, we've done a really poor job of basically managing hepatitis C in the cascade. So this is our cascade of care. We've got over 200,000 people estimated to be infected with hepatitis C, and really we've had a reasonable level of diagnosis in terms of people being diagnosed as antibody positive, but not a high follow-up in terms of people being RNA positive and knowing their RNA status, let alone people going on to treatment or cured. That is about to change. It is changing right now, but that's where we've been. And this is the kind of problem in our country and many other countries that we're going to get if we don't change that. We're going to get increasing disease, increasing deaths, increasing cost. The WHO targets, and I think that they're really fantastic, and for me, as a person who was involved in some initial work in the workshop around it, it was really interesting and great to be involved, but also I was able to use it as a very powerful tool because around this time in Australia, negotiations were going on in terms of pricing. And I was basically arguing with a few people, but not everybody, that treatment should be available for everybody in Australia. We should be aiming for elimination. We should not be being timid about this. We should be being brave, and we should be showing leadership. And this concept of only treating people with severe liver disease in a country like Australia was an anathema. We would get nowhere. And so it was really useful to go back and saying, actually, WHO are going to declare elimination guidelines, and we're going to look really foolish if we have a treatment strategy that doesn't embrace these. So I used this very much in my discussions with people in Australia and with community-based organisations, because I think that's important to have community-based organisations to say, be brave. My argument was they had to ask for the pony. I want a pony for Christmas. I don't want a little Barbie doll or any that kind of crap. I want a pony. And to go in and ask the government for a pony, and that we as clinicians had to ask for the pony and everybody else had to ask for the pony, and stop being wishy-washy about this. So I found it really useful, and I commend WHO for it. Why is elimination possible? And I think, and I often put up this slide, and this is work by Peter Vickman, Natasha Martin and others, which basically showed that the models in terms of people who inject drugs, but it's not just people who inject drugs if you look at other models, but for Australia it was this, that you didn't have to treat everybody immediately to begin to reduce prevalence and incidence. If you had a strategic plan where you were treating depending on your background prevalence, 40, 60, whatever number it was per 1,000 people who injected drugs each year. And this was with the old treatments that you could begin to make real progress. And I saw Peter present this well before the new drugs were coming. And I can remember I was working and treating people who inject drugs, and people tell me I was being foolish and blah, 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 and I was medically negligent. I remember some of my colleagues called me negligent for treating somebody that asked to be treated. I can remember thinking, interesting concept, medical negligence. But this made me reassured that we were on the right track and that we should be treating people who inject drugs, and we should be setting up for when the new treatments were coming, because you could see them coming. And this is why it's achievable, because it is easy to treat anyone. And when people talk about people who inject drugs not being able to be treated, and the issue of reinfection and all of those, what I call rather interesting and muddled thinking, people who inject drugs take drugs. The evidence showed when that was pegylated interferon and ribavirin, their treatment outcomes were just the same as for anybody else. The issue of reinfection gets cited, and I would simply say I can't think of another disease where anybody would ask such a silly question. Would we not retreat somebody's syphilis? Would we not retreat somebody's cardiac disease? Well, we don't question behaviour. Put that cream bun down, no butter in the refrigerator. I'm sorry, I saw you smoke. No, you could just have your heart attack there while I don't give you the next lot of CAGs or stents. We would see that as preposterous. So let's just think whenever we get asked the question of retreatment for people who inject drugs, for gay and bisexual men, for anybody, that the issue of retreatment is preposterous, because these drugs cure, they cure again and again. So I just think they're simple, safe and effective. But it's only going to work, and we're only going to achieve elimination in countries where disease is driven by people who inject drugs, is if we treat them. So that's really important. Our models that we've done, and this is work by Nick Scott in my group and it's been published in Gut, essentially show an important thing. We can achieve the WHO targets for basically stopping deaths by treating around 5,000 to 6,000 people per year in Australia. But we will bring the deaths down, that lower arrow, but we will not bring the prevalence down. But if we treat that same number, 5,000 plus, with significant liver disease for 5 years, but also just treat around 4,000 to 5,000 people who inject drugs every year in Australia, we can both achieve the elimination targets for deaths and we can achieve the elimination targets for transmission. We can get it down to that less than 90% or less than 10%. So we can achieve both by not doing much. It's just a matter of saying, how do I treat 5,000 people who inject drugs every year and around 5,000 to 6,000 people who've got significant liver disease? Is this hard? No, it's not. And no, it's not, because we had a really good negotiation in Australia that went on, and we held out. We had a tough negotiator. She scares me a little. Not Susan Ley, our minister, who made a very brave decision to make these drugs available for everybody, and she was on the conservative side of politics. But she had decided, because it was cost effective, that treatment would be made available for everybody at any level of disease, no matter how they got it, and there were no rules around not retreating. She knew exactly what she was doing, and she used, when the announcement was made, the eradication word. We have a decision being made, and the actual full negotiations are not known, but we know that basically we can treat up to a certain amount where about just over $1 billion was made available. And in that $1 billion, we know that a treatment cost comes in at around $20,000-ish, $18,000 perhaps. But once we reach a certain amount of $200,000 plus being spent, $200 million plus being spent every year, then the risk is shared between the companies and the government, and that treatment becomes less. So we can treat as many people as we like. We have a cap. And my view is that we are not doing the right thing by this woman who took a political risk if we don't break that cap every year. So drugs became available to everybody on the March the 1st, 2016. We did not have elimination targets in Australia. We have national strategies. And as much as I tried to get them written in, it was one of those things that, you know, when it gets knocked back between you and the bureaucrats, every time you write something in, they take it out again. And after about the 5th time, I thought they're just not going to do it before the WHO announces them. But our state government in my state have announced elimination targets, which are a bit even further advanced than the WHO ones, but of course we should, because we've got an opportunity to do more. And already this year, and this is work being done by the Kirby Institute, Greg Dorr and others, are following treatments. And in the first few months in Australia, we've treated over 30,000 people. And it's likely that by the end of the year, we're expecting that really over 40,000 people, which is nothing compared to Egypt, but that's well within our elimination targets, will be treated in the first year. And this is more people treated than actually were being treated in total in Australia prior to that in total. So it's possible. But what's not clear is whether we're treating people who inject drugs, and we need to get that up. And we need to do that by engaging with that population. Because this is further modelling which is currently out under review, which showed by Nick and others in my group, which are essentially saying we're not going to do it if we don't take treatment into the community. We're not going to do it if we don't have high quality harm reduction. We're not going to do it if we don't have people having quick access to fibrosis scores, be it in a pre and then an on-site FibroScan, and we're probably not going to do it if we don't have point-of-care testing and regular testing of people who inject drugs. That's scenario 5 down on the left. So this is not going to happen by chance. We're not going to actually eliminate in your populations by chance. You have to say, what do we need to be doing in our population to achieve this goal? Sorry, wrong way. So basically, scenario 5 for us is treatment in the community of people who inject drugs using rapid point-of-care tests, a pre and FibroScan, and regular testing of all people who inject drugs after that, because you need to do retreatment if necessary. And the argument I say with retreatment is if you're not actually seeing any retreatment, you're probably not treating the right population, because you need to treat people who currently inject drugs who are the transmitters. So what are we doing about this? In my state, we've got an Eliminate study where we've got a major partnership between tertiary hospitals, primary care services, community and government, where we're basically aiming to treat the sufficient number of people to eliminate in the next 10 years, called the Eliminate C study. It's a broad partnership, and it's the kind of thing that you need to do, you need to engage with everybody. And the idea of this is to facilitate our health services to achieve these goals. As I said, because I don't think it's going to happen by chance. We're looking at network-based approaches where we understand that a person who injects drugs invariably doesn't inject on their own, but injects with each other, so a treatment as prevention approach using a network, which I won't go into details for want of today, but people will have heard me talk about this, and the key message is that we know that if we treat a person and their injecting partners, the prevalence goes down per treatment. I think network-based approaches also would work in gay and bisexual men, but also I often think about within Egypt, if you think about how transmissions are occurring within health services, within villages, official and non-official, to take a network-based approach and what I would call think global but act local in terms of how you think about your epidemics. The PRIME study is looking at basically a randomised control trial of saying treatment in the community. Does it work? Compared to having somebody referred up to the tertiary hospital. We know that every time somebody needs to leave the health service where they might be getting their needle and syringes, their OST, whatever it is, that we lose them. So we think we do, we see that with HIV, but we actually don't have that clear evidence in hepatitis C, but this is a study to provide evidence to say treat locally. It seems obvious, but we need evidence, we need science. There's some really great work being done up in New South Wales and with the Kirby and community-based organisations around health promotion, engagement with the community to get people to be being tested, awareness and those kind of things. Actually know that treatment's available. You can come in and be cured. FibroScans or community-based testing. We're doing a combination of things. Essentially, we're trying to work out, again, with resourcing, where it's not, endless. It is not what we call in Australia a magic pudding, where it just doesn't get eaten, it disappears. There is resourcing issues. But if you're doing a pre-score, it comes in at less than 1. Work that we're done, which is not published, but I would suggest SCO, the likelihood in community that a person with a pre of less than 1 having anything like significant liver disease is so low that you can just treat them then. If there's a pre greater than 1, then you might, in a country like Australia with resourcing, say I'll do a FibroScan, and then make a decision. If that FibroScan score is less than 12.5, treat in community. If that FibroScan score is greater than 12.5, send them up to the tertiary hospital for management and care. That means that in terms of the pre less than 1, 60+% of people don't need to go on to have anything more except the standard blood workup in terms of keeping it simple and can be treated in community. Another 30 to 40% might need a fibrous scan. Why not in community? It's not hard. Basically, those people, another 30% of those can be treated in community, and only 5 to 10% ever need to go to a tertiary hospital in Australia, in my view. So that's what is the way we're trying to work it, and again, work by our group in Melbourne, Jason Grebley, Greg Dora, Andrew Lloyd and others in Sydney are showing this is a way forward. In terms of treating HIV positive hepatitis C co-infected gay and bisexual men, this is a real way of thinking about think global, treat local. Invariably, when you look at the molecular epidemiology, it's a separate epidemic to the epidemic among other people who inject drugs. It's driven by both a combination of sexual risk behaviour and drug risk behaviour. And we've got studies basically aiming to go, let's eliminate, let's do it in 2 years. In my view, we can do this in cities across Europe if we just make treatment available to all. So think global, act local within your local networks of gay and bisexual men. So we're doing this as nurse-led models of care in high caseload services, and these are being shown to be very effective in getting people through the door. Gail Matthews and others in Sydney are doing similar work. As well, work in prisons, and I'm not going to go into details because I know that Andrew Lloyd's going to be speaking about this, I think, later today or tomorrow. But in essence, if you think about prisons, they're a public health opportunity. We're invariably locking up people for all the wrong reasons, and often we incarcerate people who inject drugs. For drug-related crimes, which if you think about it, it'd be a good idea not to be doing it. But if we are doing it, let's use it as an opportunity. If you think that a vast proportion of people in our prisons have a history of drug use, high proportion we know from the recent Lancet series are hepatitis C infected, then let's have treatment programs in prisons. And let's structure those programs so that we try and treat as many people as possible, make sure if they're coming out of prison they get handed over appropriately, because this is how we'll be able to impact on our epidemic. Andrew's doing work in New South Wales. Alex Thompson, who I work with a lot in Melbourne, is able to gone from treating less than 20 people a year last year in our prisons. This year he's treated over 400 people already, predominantly people who inject drugs. So again, if that's how do we get up to that number we need to eliminate, then prisons are a perfect place for it. Prisoners are interested in having treatment. All of our work shows that. Andrew's work shows that. For me, stigma and discrimination, as I said, is a really key issue. And we have to keep on addressing this globally and never let it go unacknowledged. If we had sensible drug laws, the war on drugs has been an absolute failure. It makes no sense at all. It hasn't resolved any of the issues around drug use within our communities, and we need to change that. And I think we as people, public health physicians, whatever our roles may be, need to constantly be reminding people that there is no evidence to support this. It has actually done enormous harm. And if we want to be successful in eliminating hepatitis C in particular from many, many countries, we need to change this. Shooting drug users is not a solution to a complex social and health problem. So for me, hepatitis C requires a strategic and multi-pronged approach. We need to increase testing, we need quality harm reduction, we need increased access to treatment and assessments. I've just put in there because I'm not talking about it today, but we do need a vaccine and we need a reduction in stigma and discrimination. I'd like to acknowledge lots of people. Thank you.